All right. Good morning, everyone. We're going to call to order the Subcommittee on Behavioral Health. Would the clerk please take attendance?
Chair Braybeck.
Here.
Representatives Arvid. Pohedsky. Here. Glanville. Here. Edwards.
Present.
McDonald. Present. Rankin.
Present.
Schmaltz.
Here.
Odom.
Here.
St. Germain. Here. Thompson. Madam Chair, you have 9 members present. You do have a quorum.
Thank you, Madam Clerk. I appreciate it. Representative Pohutsky moves to adopt the minutes from the November 9th meeting. Without objection, the minutes are adopted. We now are going to have testimony on House Bill 5114. Rep. Reingans is going to be testifying in front of us. Good morning, Rep. Thanks for being here.
Good morning, and thank you, everybody else, for also being here. Thank you, Chair and members of the committee. I am here today to talk about a bill in the patient-led care package, HB 5114, which is a bill I sponsored. As you all know, in this committee especially, as a state and as a nation, we are experiencing a mental health crisis, and it is compounding. Currently in Michigan, 4.2 million Michiganders live in a mental health professional shortage area. And 38% of Michiganders with mental illness have an unmet treatment need, and a whopping 72% of Michiganders with a substance use treatment need have it go unmet. 72%. In other words, there are thousands of Michiganders struggling with behavioral health issues right now and unable to receive necessary care. This bill would help address the provider shortage issue by amending the mental health code to add physician associates, nurse practitioners, and clinical nurse specialists to the definition of mental health professionals. Around 30 other states already have these professionals recognized for the education and training that they have already received. As it stands, PAs, NPs, and CNSs are all educated and trained in psychiatric medicine. However, because they're not currently recognized under our state's legal definition of mental health professionals, sometimes they're unable to provide aspects of needed behavioral health care. Patients in distress may see a PA, NP, or CNS in an emergency room, an inpatient psychiatric facility, or in an outpatient mental health facility, all places where all of these practitioners already work. In some situations, these practitioners are prohibited from administering mental health care that they have already been trained how to provide, forcing struggling Michiganders to continue to languish until they can see someone who is currently classified as a mental health provider. My bill alone won't fix the entire mental health crisis we have here in Michigan. It will help in a tangible way by allowing more providers to deliver the mental health care that they have already received training for and in workplaces where they're already based. Madam Chair, members of the committee, if we're serious, and I know we are, in addressing the mental health issues facing our state, we need to allow all practitioners who have been trained in behavioral health to be able to provide the care that our Michiganders desperately need. Eventually, I will be urging you all to vote yes on HB 5114 to do that to help our Michiganders. Thank you.
Thank you, Representative. Committee, are there any questions? Representative Schmaltz.
Thank you, Representative. So you said some 30 states have this same.
Approximately 30 states.
Is it the same type of legislation?
So in their mental health codes in their states, they already recognize these practitioners that have already been trained in mental health. In Michigan, as we were writing our mental health code in the 70s, we just didn't add these providers at that time. And now it's time to do that.
Okay, thanks.
Thank you.
Any other questions for Representative Reingans? Okay.
All right, thank you.
Thank you very much. We appreciate it. We're not going to hear further testimony. First, we have Corwin Ryan, who is on Zoom with us. And we have 5 folks who we know are testifying. Each person will have 5 minutes. We'll keep track as you get to about a minute or 30 seconds, or we'll do 30 seconds. I'll raise my hand so you know, just so that everyone can have the same amount of time. So thank you all for being here. And we have the research director from Altarum Institute again on Zoom with us. Oh, we just lost him. Oh no, there we go. Good morning.
Am I still here? Good morning.
You
Can hear me?
are. Yes, we can see your slides now.
Wonderful. Fantastic. Good morning, Chairwoman Braybeck and subcommittee members. I'm Corey Ryan. I'm a research director on the Health, Economics, and Policy team at Altarum. Altarum is a Michigan-based nonprofit that conducts work with states, foundations, and the federal government to improve the health of those with fewer financial resources and populations disenfranchised by the health system. I'm the lead author of a report that was published in December 2022 that assessed access to behavioral healthcare services in Michigan and estimated the level of unmet need for mental health and substance use disorder treatment within the state. The report was commissioned by the Michigan Health Endowment Fund and was a continuation of work that began all the way back in 2018 studying this topic. The most recent work updates the estimates of behavioral healthcare access from 2016, adding in new data from 2019, and compares trends in behavioral healthcare use and access to behavioral healthcare services in Michigan over time. The work estimates the overall need for behavioral healthcare services in the state and compares that need to the number of individuals who actually received care. And we use a very basic definition of access. How many individuals with a behavioral healthcare need in Michigan received care at least once within the year of study? Before I discuss my study's findings, it's important to acknowledge and recognize the state's ongoing commitment to improving access to behavioral healthcare services for all Michiganders, and that this study's data are through the year 2019. The work found that between 2016 and 2019, the rates of those receiving care for behavioral health care conditions improved, likely driven in part by an increase of behavioral health providers in the state over that time. However, during the same period between 2016 and 2019, the prevalence of behavioral health care conditions increased significantly in Michigan, following a nationwide trend of a higher prevalence of both mental illness and substance use disorder needs across the country. In 2019, 20.2% of Michiganders had any mental illness, and 5.9% of all Michiganders had a substance use disorder. This means nearly 2 million Michiganders had any mental illness, and 580,000 had a substance use disorder need at that time. Among those with a behavioral health care need, the share of Michiganders with a mental illness who received care between 2016 and 2019 increased from 62% to 68%, and the share of Michiganders with a substance use disorder who received care increased from 20% to 28% in 2019. Mental illness rates and unmet need in 2019 were highest among adolescents, women, those who were uninsured, and those on Medicaid. Anxiety disorders and depression were the most common mental health conditions seen in the state over this time period. And substance use disorder rates and unmet need in 2019 were highest among adolescents, among men, and those who were also uninsured. Alcohol use disorder was the most common substance use disorder in Michigan in 2019. As a result of the ongoing nationwide trends in prevalence increasing that I discussed, the level of unmet need for both mental illness care and substance use disorder treatment remained high in Michigan in 2019. An estimated 640,000 Michiganders, or about 32% of those with a mental illness, had an unmet need for that care in that year. 420,000 Michiganders, or a whopping 72% of those with a substance use disorder, were also untreated for their condition in 2019. While the number of behavioral health providers increased in Michigan between 2016 and 2019, provider capacity remained significantly constrained, particularly in the northern half of the Lower Peninsula and portions of the Upper Peninsula as well. In 2019, 22 counties in Michigan were without either a psychologist or a psychiatrist, and 9 counties had neither of those two. 20 counties in Michigan lacked a dedicated substance use disorder treatment facility as well. Given the continued level of need for behavioral health care services, our reports made a variety of recommendations for how Michigan can continue to improve access to care for all Michiganders. These recommendations include opportunities to increase the effective supply of providers and ways to make those providers more accessible to those living in all parts of the state, additional recommendations to improve the affordability of care, and ways to improve the willingness of the public to seek treatment for their mental health and their substance use disorder needs. Alongside these recommendations, it is important to recognize the MDHHS investments in behavioral health care services and its continued commitment to ensuring Michigan families can more easily access behavioral health care services. Our complete series of reports are available at the provided link to the Altarum website, and I look forward to any questions you may have for me about the report. Thank you very much.
Thank you so much, Mr. Ryan. Committee members, does anybody have any questions on the Altarum studies? It doesn't look like it. Thank you, Mr. Ryan, for being here with us today. Next, we have Bindya Nadwana, who is a PA and the clinical director from Wayne State University, and Thad Gormis, who is the executive director from the Michigan Academy of Physician Associates. Morning. Welcome.
Dear Behavioral Health Committee, my name is Bindya Caruana, a licensed physician assistant in primary care and the director of clinical education from the Wayne State University's PA program. With over 10 years of experience training PA students, I'm here to express my strong support for Mental Health Bill 5114. I'm here to express my patient care is a core priority in both my practice and the education of future PAs. Our profession is built on improving healthcare access, quality, addressing provider shortages, and which include behavioral health. In Michigan, based on some recent statistics provided by the National Alliance of Mental Illness, there are approximately 1.5 million people who need mental health care services daily in Michigan, and often care can be hindered by provider shortages for these patients. As a primary care provider, I witness this challenge firsthand. Primary care providers, including PAs, oftentimes manage anywhere from 30 to 40% of psychiatric illnesses within the primary care setting, and oftentimes this is due to long wait times and shortages of access to appropriate behavioral care services, and this trend unfortunately continues to grow. Recognizing this need, there has been a significant growth among PAs practicing behavioral medicine. As an educator, I can attest that PAs are well prepared for this role, given their rigorous educational training and background. PA students undergo a comprehensive 2 to 3 year postgraduate training program requiring strong undergraduate background in medical science. At Wayne State University, we have a stringent prerequisite requirement ensuring students have a solid foundation in pathophysiology, anatomy, organic chemistry, human biology, psychology, and developmental psychology prior to even entering the program. Most of these students follow a pre-med track and graduate oftentimes at the top of their class. For Wayne State's PA class of 2023, our average undergraduate GPA was 3.73, with a prerequisite GPA of 3.89 in respective to their science coursework. And according to U.S. News and World Report, this was slightly higher than the average GPA of successful applicants to the allopathic medical schools between 2018 and 2019, who had average science and overall GPAs of 3.65 and 3.72 respectively. PA students are very well prepared for this. Students also have an extensive healthcare experience and background prior to attending the program. That is a unique criteria compared to other healthcare programs. Our recent graduates from our class of 2023 had over 3,000 plus hours of healthcare experience in various fields prior to even being admitted to the program. And these areas can include previous RNs, respiratory therapists, medical assistants. They come from all different types of healthcare fields. And once you're in the PA program, students are guided through a 12-month rigorous didactic curriculum. This intensive education includes 40 plus hours of in-class training per week in clinical medicine, pathophysiology, anatomy, pharmacology, and patient evaluation. This is followed by 12 months of hands-on clinical training in the field. And during this training, students work alongside medical students, residents, and receive training from our physician and PA colleagues on the application of their medical skills. They obtain these skills from board-certified providers and or their trained associates. So for example, a psychiatrist would train a PA student in the field on behavioral medicine. Wayne State's recent cohort amassed approximately 1,700 hours of hands-on patient care experience during their clinical rotations. I underscore the extensive training PAs undergo, positioning themselves as invaluable members of the care team. Supporting Mental Health Bill 5114 aligns with our shared goal of ensuring safe and quality care for patients. By recognizing PAs in the Mental Health Code as mental health providers, this bill paves the way for improved access to care and collaborative efforts to enhance overall patients' well-being. It is a step towards acknowledging the vital contributions of PAs in addressing this mental health needs of the community. Thank you.
Thank you so much. Mr. Gormis, and then we can take questions.
Thank you, Chairwoman Braybeck and committee members. I'm grateful to be here today on behalf of the Michigan Academy of Physician Associates and the 8,000 Michigan PAs that we serve. This bill is intended to support specific patients in your community. House Bill 5114 was introduced as part of a bipartisan package, as mentioned by sponsor Representative Rankins. The bills are known as the Patient-Led Care Package. These Michigan patients simply want care from their PA when they need it. PAs serving your community have shared stories with you about the patients that are exposed to harm because of two issues. That is what this bill addresses. The FAQ document in front of you from the Michigan Academy of PAs, the Michigan Council of Nurse Practitioners, and the Michigan Hospital Association, it says the bill addresses two issues. One, the bill defines PAs, NPs, CNSs as mental health providers. These licensed professionals are mental health providers today. Leaving them out of the definition exposes patients to harm. Patients are exposed because PAs are not included in legislation referencing this definition. Patients are exposed because hospitals, clinics, and behavioral health practices don't know they can hire these mental health providers. They don't know. Most importantly, patients are exposed when they do not trust their mental health provider. We know patient trust is one of the most important predictors of healthy patient outcomes. Why would anyone want to receive mental health care from someone who's not a mental health provider? All Michigan patients deserve to have their mental health providers defined as mental health providers. That is the first patient issue this bill addresses. The second issue this bill addresses is ensuring that PAs, NPs, and CNSs whose patients are experiencing a dangerous psychiatric emergency may get in to see a psychiatrist. This process is known as an emergency up to 24-hour hold or first certification. An emergency up to 24-hour hold requires a patient to be seen by a psychiatrist as soon as possible and within 24 hours. The bill ensures only a psychiatrist will determine the need for involuntary treatment, only a psychiatrist. All Michigan patients deserve to be protected from dangerous psychiatric emergencies. This is the second patient issue this bill addresses. These are the two patient issues addressed by House Bill 5114. Finally, here are two things that House Bill 5114 does not do. First, the bill does not change which of these providers can manage safety restraints. It is important that you understand this detail. PAs, NPs, CNSs have the authority in law to manage safety restraints in every setting, including the psychiatric inpatient setting. This bill does not change that in any way. Second, this bill does not allow for anyone but a psychiatrist to admit a patient involuntarily. Only psychiatrists have the authority to admit a patient involuntarily in Michigan. This bill does not change that, which can only be done by a psychiatrist. These Michigan patients are fortunate for the psychiatrists, physicians, psychologists, counselors, registered nurses, and other defined mental health providers who support House Bill 5114. You can read the long list of medical provider associations and other health stakeholders on the last page of the FAQ in front of you. Testifying in support, you will hear from psychiatric PA Allison Badger and psychiatrist Dr. Laura Hirschbein from the University of Michigan Medicine. They have practiced psychiatric medicine alongside each other for over a decade. Every psychiatric hospital in your community includes PAs, NPs, and CNSs providing mental health care. Even the state of Michigan psychiatric hospitals are trying to hire psychiatric NPs and PAs. Psychiatric medicine is the fastest growing specialty for PAs. Please support the patients in your community currently receiving mental health care from their PA, NP, and CNS. Thank you for your time and allowing me to summarize the need to address these two important issues.
Thank you, Mr. Gormas. We appreciate both of you being here and testifying. Colleagues, any questions for either of these folks? Okay, thank you so much. So next we do have Allison Badger, who's a psychiatric PA at Michigan Medicine, and Dr. Laura Hirschbein, who is a psychiatrist at Michigan Medicine. Come on up. Thanks for being here this morning.
Thank you, Chair Brabeck and subcommittee members for allowing us the chance to talk to you about this today. I'm not going to share all my statistics with you because the people who've spoken before me have already done a lot of that, so I'm not going to belabor that. But I do want to add one thing. According to the Michigan Department of Health and Human Services, a Michigander dies from suicide every 6 hours. That's 1,400 people a year or more. In the 8 years since we first proposed to have our names admitted to the mental health code, we've lost more than 12,000 people to suicide. These are unnecessary. These are preventable deaths. How long are we going to keep doing this? And how are we going to justify that we're doing this, that we're squabbling over initials in the mental health code? Well, people die because they don't have access to care, because hospitals don't know that they can employ us. Doctors don't know how we can help. My colleagues are leaving the state. I was just recently working with a PA student. She's interested in psychiatry. She's actually interested in geriatric psychiatry, which is a really tiny niche, but everybody knows about our aging population, correct? Well, she came to the Flint School, University of Michigan Flint PA program, because it was a great program that drew her. She came from Cleveland, but she's going back to Ohio to practice because she knows about the problem with our mental health code. She wants to be able to use her training and her skills. She wants to save lives. She wants to prevent suicide. And so do we, all of us. So I want to just tell you a couple of stories about patients that I've worked with. When I worked on the inpatient unit with Dr. Hirschbein, I was working on a Saturday. I was the only provider still on the unit. Other people had seen their patients and gone home. I was waiting for a special admission coming from an outside hospital. This was a frail, elderly woman. She was medically ill. She was psychiatrically unstable. She had psychotic depression. She was not in touch with reality. She was not able to sign herself in voluntarily for treatment, which we knew she needed. She was coming from another hospital. Because there was a delay at the hospital who was sending her to us, her first certification had expired by the time she arrived. I couldn't admit her. I couldn't give her medicine. I couldn't have her lie down. I had her sit in a room alone, terrified, shaking, ill, while I went and hunted up a physician. Just a physician. Didn't have to be a psychiatrist. I found a psychiatrist, but I could have gone down to the ED. I could have found anybody. I could have found a resident in their first week of training to sign that cert. They didn't know the patient. I did. I had planned her admission. I had prepared for her. I knew about her. I knew her history. I had spoken with the psychiatrist who was transferring her from the other hospital. I was prepared to care for her, and I couldn't because I couldn't sign that certification. Is that okay? That's not acceptable. When I worked in an outpatient community clinic, I worked with kids and adults. I had a kid who had made death threats at school to her peers, to teachers. She wasn't allowed at school anymore. One day when she was in my office, she became very agitated, very upset. She was throwing chairs at her parents. She was trying to pick up tables to throw them. She tried to open the window of my second floor office to jump out. I couldn't send her to the hospital because EMS won't transfer a patient without a cert. I couldn't sign a first certification to get her the medical care that she needed, the psychiatric care that she desperately needed, so EMS wouldn't transport her. But my office staff could call the police? Why should she be one of the 70% of kids in incarceration right now who have at least one mental illness? Why should she be in juvenile detention instead of getting psychiatric care? So those are the stories that I wanted to tell you, that I wanted to share with you, because we have statistics, and when it's many, many, many people, it's a statistic, but when it's one patient, when it's one story, that's a tragedy. So I thank you for listening.
Thank you very much for the opportunity to testify, and I apologize that I've got a lingering laryngitis, so I'm going to croak at you. I'm sorry. The world was very different a half a century ago when the Michigan Mental Health Code was first enacted. A University of Michigan graduate, Gerald Ford, was in the White House, and the Detroit Lions were still playing at Tiger Stadium. Psychiatric care consisted of either long-term psychoanalysis or long-term institutionalization at one of Michigan's dozen state psychiatric hospitals. As a clear marker of how different things were at the time, psychiatric medication in the original mental health code was referred to as chemotherapy. The original mental health code did not specifically identify physician assistants or physician associates, nurse practitioners, or clinical nurse specialists. But that was not because they were deliberately left out. It was because those roles did not exist in mental health settings at the time. We need to amend the mental health code to include these types of providers because it reflects the expanded composition of our modern healthcare team. We also need to make sure that we're doing everything we can to enhance the safety of all by recognizing our advanced practice provider partners in our systems of care. The two specific practices named in the mental health code that are affected and or could be affected by this proposed legislation are the ability to complete a first clinical certificate and permission, as some health systems are interpreting it, permission to authorize seclusion and restraint for patients on behavioral health units. Let's say you have a young adult neighbor who seems to be behaving strangely. He's up all hours of the day and night, wandering the neighborhood without making eye contact with anyone. One night he appears out in front of his house with a gun and is just standing there. His mother gets the police to take him to the hospital, and she fills out a petition explaining what she's seen and heard. At the hospital, the young man is seen by a physician associate who takes the time to interview the patient and the family to understand what's going on. The PA appropriately concludes that the next step is to admit this young man to the hospital, where he can then be seen by a psychiatrist. But the young man does not want to go. As it stands now, the PA cannot complete the first clinical certificate need to hospitalize the young man. Instead, he has to find a physician, any physician, even the intern who was a medical student days before, to complete the form. Or if there isn't a physician around, he has to let the patient go. Now, let's say this young man is admitted to a hospital that is using their understanding of the mental health code. That means that if there is an emergency and someone needs to be restrained or secluded, that only a physician can sign the nursing order. If this young man is admitted to the hospital but becomes paranoid and unfortunately assaults one of the nurses might understandably put the patient in restraints to keep him from harming other people. The psychiatrist who rounds at the hospital is only there for a few hours every morning, but has hired a nurse practitioner to be available on the floor the rest of the day to attend to patient needs. As it stands now, for some hospitals, including ours, if the patient goes into restraints at a time when the physician is not able to see the patient within an hour, the patient has to be released, risking more staff assaults. In the old days, healthcare systems relied on exploiting the labor of resident physicians to staff hospitals and emergency rooms. Today, we have both residents, who hopefully are less exploited, and advanced practice providers to cover hospital and emergency spaces. APPs are also critical members of our outpatient teams, especially since there's a nationwide shortage of psychiatrists, as we've seen. The response of many healthcare systems to the mental health code restrictions on APPs is to limit the number of patients who might need involuntary treatment or could be at risk of becoming aggressive. The fact that the code does not explicitly name APPs has further limited access for the higher acuity patients who sit in emergency departments for days to weeks. And this particular issue of the definition in the mental health code came up when I had the privilege of chairing the Certificate of Need work group on psychiatric patient beds in 2019, where we hit the resistance of we could not name certain facilities as authorized to have psych beds because they didn't have providers who were explicitly named in the mental health code. There are some things that would not change if HB 5114 became law. No matter who completes the first clinical certificate, a patient cannot be treated against his will without an evaluation by a psychiatrist and a court order by a judge. There's no reason to think that the incidence of seclusion and restraint would change regardless of the interpretation by health systems. Those restrictions are initiated by nurses who are managing patients' acute behaviors in the moment. The restraint and seclusion orders act to validate nursing action, not typically as instructions for nurses to take action. The mental health code has to change with the times. A half century ago, no one could have predicted that we would all carry small devices that can function as cameras, computers, and phones. Along with new technologies, we've also acquired new members on our mental health team who need to be recognized. Thank you.
Thank you, Dr. Hirschbein. Colleagues, any questions for Allison or Dr. Hirschbein right now? Okay. Thank you so much for being here and outlining and bringing those stories. Really appreciate it. The final person here with us is Umika Griffith-Stevens. She's a psychiatric nurse practitioner and professor from Wayne State. Welcome.
Press the button.
That's great. Thank you.
Of course, you get to hear from yet another warrior. Good morning, Chairperson Braybeck and the House Behavioral Subcommittee. My name is Umika Stevens, and I'm honored today to represent numerous advanced practice psychiatric nurse practitioners, as well as the nurse practitioner organization, the Michigan Council of Nurse Practitioners, as also Wayne State, as I am the graduate specialty coordinator for the psychiatric nurse practitioner program, and have been so for the last 10 years. Is there a question? Okay. I am here today to share with you how nurse practitioners can assist with addressing the tremendous unmet need for the care of the acutely mentally ill. As it has already been stated, the Michigan Mental Health Code is not in line with other Michigan statutes. The climate of healthcare has significantly changed since 1974, when advanced practice nurses were not yet fully actualized. We think that is very clear already from our previous information. But over the past 5 decades, advanced practice registered nurses have proven that we can improve costs, access, and quality to care services. The inclusion of nurse practitioners and clinical nurse specialists in the Michigan Mental Health Code will positively impact the provision of comprehensive services for mental health for patients living with these illnesses. The prevalence of people living with psychiatric illness, as we already see, is a significant public health concern. Illnesses such as schizophrenia, bipolar disorder are costly to individuals, insurers, government agencies, but mostly for the patients and their families living with these diseases. The National Alliance on Mental Illness estimates that 1 in 5 adults suffer from some type of mental illness. And the consequences when these are untreated include incarceration, homelessness, substance use, suicide, and hospitalization. But one of the major concerns for patients living with psychiatric illness is access to quality healthcare providers that can provide comprehensive care. Psychiatric advanced practice nurses are trained in the competencies to meet these needs. The very first graduate nursing program ever in the United States was in psychiatric mental health nursing in 1954 at Rutgers University. So we are not new. We have been around for a very long time. Since that time, advanced practice psychiatric nurses have provided mental health care, including independent assessment, evaluation, treatment management, psychotherapy across the spectrum. Nurses pursuing psychiatric nurse practitioner credentials are already registered nurses. They have a bachelor's degree from accredited schools, and on average for our program, have practiced as psychiatric nurses for 5 to 7 years before they come back to pursue their advanced practice credentials. They already have gained competencies in their basic education in therapeutic communication, assessment, diagnosis, and care planning. And as already laid out by, I want to say Dr. Hirsch, I don't want to mess up her last name. But in inpatient settings, these are the nurses that are taking care of and making decisions about what are happening with these patients. Graduate psychiatric education builds on that foundation and leads towards either master's or doctoral education. Students are required to learn psychopharmacology, psychiatric assessment, diagnostic evaluation for patients across the lifespan. As we already know, psychiatric advanced practice nurses practice in a variety of clinical settings, but irregardless of the setting, there are concerns about destabilization that can lead to patients becoming a danger to themselves or others. And during these periods, it often requires hospitalization to maintain the safety of the patient and the community. All psychiatric advanced practice nurses are trained to be proficient in suicide and violent risk assessment, crisis intervention, and have the necessary skills to complete that first clinical certification for hospitalization. As a psychiatric nurse practitioner practicing in the state of Michigan for 23 years, I have to mirror Allison, and this has been a stressor in every clinical environment I have ever practiced in. I have often been where I'm the only prescribing provider in the clinic, or I'm working on a service where I am the person on call. Patient presents in crisis, and in these situations, I'm either forced to send a patient via ambulance to a hospital or attempt to get my collaborating physician to hopefully try to do a direct admission to a psych hospital if that's even possible. Either solution costs time and money and distress to those patients. And it is frustrating as a provider that I have an established clinical relationship with these patients. I am well-versed on their psychiatric illness, but I am limited in their times of crisis. These changes to the Michigan Mental Health Code are invaluable to improving the care of the acutely psychiatric patients and improving utilization of mental health services. Increasing the workforce of nurse practitioners that can facilitate hospitalization in crisis will improve the safety for our communities and for our individuals. I thank you for allowing me to contribute to this important discussion, and I'm happy to answer any questions that you might have.
Thank you so much. I really enjoyed learning the history. I did not know that.
Yes.
Thank you for sharing that with us.
And actually at Wayne, we actually are one of the oldest programs in the state, or actually in the state and in the country.
That's amazing.
Yeah.
That's amazing. Colleagues, any questions? Okay. Representative Edwards.
Thank you, Chair Brayback. In your statement, you said a statement, if that's even possible.
Yes.
Could you elaborate on that so that some of us can understand what you meant by that? I mean, I understand what you meant by that, but let's just elaborate a little bit more.
This bill is not going to address the second half, which is mental health beds in the state of Michigan. So even if we do send somebody for hospitalization, there is often sometimes waits because there's places that, as the physician talked about, that may not have a certificate of need, so now they don't have any beds to send someone to in a crisis. And so these patients are now waiting in the ER for whatever bed that they can get. So if it's even possible to get them to the psychiatric hospital. So this bill does not address that. If y'all, you want to create a bill for that, we'd appreciate that. But that becomes another part of it. But if we can at least be able to get them in that first step, it is a level of frustration when you're trying to get somebody who's in acute crisis help, and our system is just invariably broken, as the report from Alterum shows. But yeah, that is often a problem, that if you can even get them a bed, and especially if you're working with adolescents, geriatrics, people who are medically ill, it's a whole nother level of stress to even get them the place they need to be.
Yeah. Thank you. Colleagues, any other questions? Okay. Thank you so much, Ramir. I just wanted to say thank you to all the practitioners for all that you do day in and day out. You are on the front lines and you know this crisis, and so we appreciate you coming here and sharing with us, clearly outlining the problem and really bringing up and uplifting this solution. So thank you. Thank you. I really appreciate it. All right, colleagues, I'm going to read in our cards that we have here. All of the ones I'm going to read now do not wish to speak, are in support of the bill. Michigan Manufacturers Association, ANA Michigan, MNA, Michigan Association of Colleges of Nursing, Universal Health Services, Michigan Health and Hospital Association, the Michigan Council of Nurse Practitioners, United Way of Northwest Michigan, and Michigan Osteopathic Association, as well as Michigan Association of Health Plans, Ascension, Michigan, and the National Association of Social Workers in Michigan. Opposed and not wishing to speak are the Michigan State Medical Society, Michigan Psychiatric Society, and Dr. Mbagwu. Thank you so much, Madam Clerk. So we were just hearing testimony on that bill today again, so we'll see what we need to do and look forward to working with Rep. Reingans on continued work with this bill. And thank you again to everyone who came out and to testify. So now we have three bills that we are going to take up. We're going to read these cards in before we vote. This is on House Bills 5077 and 5078. Do not wish to speak in support of the bills, Department of Health and Human Services and M&A. And for 5179, not wishing to speak in support of the bills, Michigan Nurses Association and the National Network for Arab American Communities. Thank you, Madam Clerk. Okay, we now will have the vote to refer House Bill 5077 to the Health Policy Committee. Representative Arbit makes a motion to refer House Bill 5077 to the Health Policy Committee. Madam Clerk, will you please call a vote?
Chair Brayback.
Yes.
Representatives Arbit.
Yes.
Pohutsky. Yes. Glanville. Yes. Edwards.
Yes.
McDonald.
Yes.
Rankin.
Yes.
Schmaltz.
Yes.
Hoadley. St. Germain.
Yes.
Thompson. Madam Chair, you have 7 yeas, 0 nays, and 3 pass. The bill is referred back to the House Committee on Health Policy.
Thank you, Madam Clerk. Representative Glanville we will now take a motion to have a vote to refer House Bill 5078 to the Health Policy Committee. Madam Clerk, will you now call the vote? Yes.
Representatives Arbit.
Yes.
Pohutsky. Yes. Glanville. Yes. Edwards.
Yes.
McDonald.
Yes.
Rankin.
Yes.
Schmaltz.
Yes.
Hoadley. St. Germain. Thompson. Madam Chair, you have 7 yeas, 0 nays, and 3 pass. The motion prevails.
Oh,
Sorry.
oh, so we got that. We all set?
I have you as a yes.
Perfect. Thank you, Madam Clerk. We now have a vote to refer House Bill 5179 to Health Policy Committee. Representative Edwards makes a motion to refer House Bill 5179 to the Health Policy Committee. Madam Clerk, will you please call the vote?
Chair Brayback.
Yes.
Representatives Arbit.
Yes.
Pohutsky. Yes. Glanville. Yes. Edwards.
Yes.
McDonald.
Yes.
Rankin.
Yes.
Schmaltz.
No.
Hoadley.
No.
St. Germain.
No.
Madam Thompson. Madam Chair, you have 7 yeas, 3 nays, 0 pass. The motion prevails.
Thank you so much, Madam Clerk. I appreciate it. Representative Schmaltz moves to excuse all absent members. Folks, I appreciate everyone being here. Thank you so much. There's no further business before us. The committee stands adjourned. Thanks so much, everybody.